Hello, everybody. Thank you for joining us again after this short break. We now have a wonderful opportunity to speak to some further clinician researchers and to ask via Slido your questions, and for me to ask questions of this group of people. We've got about an hour with these folk. We're still waiting for just one or two people to join. I might briefly tell you about each of these people, and then we can throw open to Q&A. Now, in case you thought that we were just awash with physicians, not that that's, I might add, physicianly medicine is the peak of medicine, and of course pediatric medicine is the best of all, but maybe I'm a little biased. We do have a surgeon here today, and it's wonderful to have Henry Pleece. Henry is graduated in medicine and completed an MD in xenotransplantation from the University of Newcastle upon Tyne in England. He trained in general and transplantation surgery in northeast England, in Edinburgh and Sydney, and he's currently the professor in surgery at the Westmead Clinical School at the University of Sydney. He's a VMO at Westmead Private Hospital and liver transplant surgeon in Salford. Great to have you here, Henry. Keep us on the straight and narrow.
Good morning.
We also have Nick Wood. Nick Wood is a general paediatrician at the Children's Hospital at Westmead, an associate professor in the specialty of child and adolescent health at the University of Sydney. He's has an NHMRC career development fellowship, and he leads the New South Wales Immunisation Specialist Service and coordinates the immunisation adverse events clinics at the Kids Hospital at Westmead. You'll probably pick up that he's very interested in vaccines, and he's got a special interest in maternal and neonatal immunisation as well as vaccine safety. Okay, great to have you here too, Nick. He also has a background in global health issues. We also have Associate Professor Hasantha Gunasekera, also known as Hass. Hass is a clinical academic paediatrician with the Kids Hospital Westmead Clinical School. He has a role in education, and he coordinates teaching for over 600 medical students annually. His clinical work is as a general paediatrician and in refugee health, and his research interests include Aboriginal and Torres Strait Islander health, refugee health and general peds, particularly otitis media, ear health. And he's worked on a range of randomised controlled trials, cohort and health service studies, and he's been a very vocal advocate to rescue children from immigration detention, Aboriginal and Torres Strait Islander health prioritisation, and many other passions. Some of you will have heard Liz Elliott's talk last week, and you will see, and there's a degree of intersection. We've also got Associate Professor Parvathi Menon. Hello, Parvathi, is that the right way to pronounce your name?
That's correct, yes.
Parvathi is a clinical academic at the University of Sydney, and she's based at Westmead. She has increasing national and international recognition in the field of ALS research. She specialised training in novel neurophysiology techniques, which she uses for clinical research. And we also have here Professor Georgina Long. Good day, Georgina. She's co-medical director of the Melanoma Institute Australia and chair of melanoma medical oncology and translational research at that institute and at Royal North Shore Hospital. She leads an extensive clinical trials team and lab at the Melanoma Institute, and she's got a focus on targeted therapies in immuno-oncology and melanoma. And she's a principal investigator on multiple phase 1, 2 and 3 clinical trials in adjuvant and metastatic melanoma. She was appointed as an officer of the Order of Australia in 2020 and has received several awards. So it's great to have you. You're quite a diverse bunch of people, various backgrounds there. And I suppose I have a number of general questions for you that the audience has put in there, but also I might ask some specific questions. So I might ask each one of you in turn to say, why are you passionate as a clinician about research? And why do you think the two go well together? And I might ask in the order that I see you. So Henry first, and then Hass.
Yeah, thanks, Louise. I think, first of all, I feel a bit of a fraud being here with such amazing people and, incredible presenters this morning, which I've really enjoyed. But I guess from my own journey, I really was a little bit unusual. I set out and went to medical school to become a surgeon. And I wanted, obviously, to be the best surgeon I could be. And I rapidly realized that wasn't just about tying knots and cutting holes. And I think, as a clinician, you're in a wonderful, very fortunate position of, I guess, having this wealth of research material right in front of you, and you're also trying to help them and aiming to get better outcomes. So I suppose my drive has been to sort of not only improve surgery, and my particular passion is transplantation. And so I was fortunate enough to get into a specialty that really is a huge collaboration. It's a collaboration between physicians, scientists, and surgeons, and nurses. So it's a sort of it's the perfect model for surgery. I just wish the rest of surgery was the same. So I suppose that gives you the overview why I sort of became very passionate, because it's part of what I see as surgery. You can't just sort of have a production line of surgical procedures. You've got to look at the outcomes and try and get better, or completely change what you do. So I think that that gives you a little bit of introduction. But if you want me to continue, I would say that I've sort of gone down different pathways, and it's totally, one of your earlier speakers mentioned the term Brownian motion, and there's a lot of good fortune and opportunities, I suppose. And it's that meeting other people and getting ideas, or suggesting ideas, and meeting people with other skills, that have got laboratory skills to prove a point, or investigate a certain technology. So in the last sort of 5 years, we've really got into different technologies that we can use in transplantation. So I never thought we would be going down that route, but it's just the nature of collaboration. And it's been an amazing experience, to be honest, in terms of trying to change outcomes. So we've been specifically looking at machine perfusion technology to try and improve kidney transplant outcomes. And I suppose that's very translatable, because it has an immediate clinical impact, which is another thing. There's I guess a clinician, I'm not sure I call myself a clinician-scientist, that's why I feel a fraud, but as a clinician, it's an immediate clinical impact, because you're really investigating and then subsequently trialing a device that can actually help patients from day 0 post-transplantation, which is something else I just love to see, that immediate impact of something that you've been investigating for, say, the last 3 years. So yeah, I feel very fortunate. I also am very humbled to listen to people on the panel, because as I say, I'm not sure I should be rightly here, but I'm absolutely passionate about transplantation, and I guess our ever improving outcomes. So
you're exactly the right person to be here, and we can already understand that from hearing you talk already.
Thank you.
Has, could you tell me about why you think being a clinician and researcher is a good thing, and why people should think about it? I know you have a somewhat different background, again, from Henry, for example.
Yes, although I have the same feeling of imposter syndrome as well, because when I got my degree as a paediatrician, I'm a paediatrician as well, I had no interest in research. I had done one research project because you had to get your physician's degree, and then hadn't approached anyone to do a PhD. However, I was interested in Aboriginal health. I'd been to the Northern Territory, and someone approached me and said, we have this Aboriginal project, do you want to do a PhD? And I said, no. And then, if I had done what I had planned, I'd be in Trinidad and Tobago or Vanuatu. That's where I was, looking to go, and was looking at house prices and things. I was very serious about going there for UN volunteers and other agencies. That's how I saw my life. But then this Aboriginal project came up, and then I'm still working on that about 20 years later. It looked so good. It was Aboriginal run, and it was going to make a difference. And I said, all right, I will do this. This looks like a good idea. And then the PhD was just because if I was going to do the work anyway, I may as well do it as a PhD. That's how it happened. So I don't know how the hell my academic career happened, to be perfectly honest. I had no intention to be where I am now whatsoever. But the reason I'm still here, I guess, is because of the question you asked, that this absolutely is a great way to do things, I think. So I still do some clinical work. I'm a clinical academic, at the Children's Hospital at Westmead. I do on call. I see, patients. I do clinics. But I'm not just doing clinical work. So I do a bit of clinical work that informs my research. My research informs my clinical work, and it's a beautiful synergy, and I'm loving it. Having never thought that this is what I would do, I now can't understand why anyone would not do this. If you're a clinician, it really doesn't make any sense to me not to be a clinical academic, really. But I'll leave it at that for the moment.
Lovely to hear you, Has, and I love the fact that people somehow take up opportunities as they come and don't have this sort of highly organised life from when they're in the womb to when they're retired. It's wonderful how you take these opportunities. I think Nick will have some interesting reflections on this question as well. Over to you, Nick.
Well, thanks, Louise. So I also a paediatrician, and a little bit like Has, sort of fell into where I am today, which is working in vaccine research at the National Centre for Immunisation Research and Surveillance. And I'm also a clinician. So way back in 2001, I was working with Médecins Sans Frontières and was wanting to come back to Sydney, and interviewed for an infectious diseases job. And partway through the interview, Professor Margaret Burgess, who was, one of the sort of forerunners of the vaccine program for Australia, said to me during the interview, "Have you thought about working in immunisation?" And at the time, I hadn't really thought about it, but I sort of worked out that probably the answer during that interview was to say yes. So I did say yes, and was offered a job to work in her immunisation centre. And that really sent me down a path that I hadn't really thought about, but I grabbed the opportunity, and it sort of fell into my interests of public health, paediatrics, because at that time most of the vaccines were given to children. And what became pretty clear to me at the National Centre was that we were writing the Immunization Handbook, and at the time I sort of thought, oh, this is pretty easy, it's all set in stone, the handbook's easy to write. But in actual fact, there were many questions for which there was no answers. Why do we give infants a 2-month, 4-month, 6-month schedule? Why not 1 month, 3 months, 8 months? Why do we do this? Why do we give boosters? And there were many questions that seemed to me to be gaps in policy that were relevant at a national level. And so that really inspired me. And so ever since that time, I've been trying to design projects and to get funding to try and fill those gaps to fill policy relevant gaps. And good examples today are, for example, with the COVID vaccines, do immune suppressed people really need 3 doses? What about pregnant women who are on biologic medicines? Do they need extra doses? Do we all need booster doses? So all of those things are sort of live questions for which there's no real answer. So I think if you'd asked me 20 years ago, would you have thought that you'd be working in a space where vaccine appears almost on a daily basis across the world? I probably would have said no, but I think I'm lucky to be in a space now where there are lots of policy questions, and then trying to design research projects to fill those. That's a challenge, but so it's an exciting space to be in right now, I think, Louise.
Thank you, Nick. Again, this sort of sense of taking opportunities when they arise. Parvathi, tell me about why you're interested in research and clinical work and how they come together.
Yeah, thanks, Louise. So I started the same way, was introduced to research fairly late in my clinical career. And I would say that I found my space finally, in that it's fairly, the thing about research is you just have to be meticulous and you have to hang in there. And that's the kind of thing which a number of clinical or clinicians are not quite keen on doing. So they just want to move on and manage a number of people. So that kind of an interest is something which helps with research. And I found that that's something I really enjoyed. So apart from clinical work, which occupies some of my time, I find that this kind of a quite obsessive kind of detailed work is very interesting. And the good news is that we sometimes come closer to finding some answers of questions that we're struggling with clinically. And that's what I found useful with my coming into research later in the career, that there were a lot of questions for which, like students would ask us questions, or even as clinicians, when you're managing a situation or a patient, you just know that you do not have an answer to that problem. And when you're doing the research work, you feel at least you're a little bit closer to those answers. Not necessarily have all of them, but you feel you're working your way towards it. And you're working and you're involved with people who are doing something similar, and that makes it very exciting. So I think it's a great balance if it's something you enjoy.
Thanks so much, Parvathi. And Georgina, do you want to reflect on this issue too? Thank you.
Thanks, Louise, and thanks for inviting me to be part of this great panel. I guess I just wanted to echo what other people have already mentioned, and it's been about opportunities, and it wasn't a planned pathway. So for me personally, I followed my passion, and really the things that, there's always a fork in the road in your career, and it was passion and engagement that drove my decision making. And the big drive, if I take a bird's eye view, was trying to make a difference to many. It's very fulfilling having a one-on-one patient-doctor relationship, but it can be incredibly fulfilling as a team of researchers to have an impact on many people. So I work in melanoma. Melanoma is Australia's cancer. When I'd finished my training in medical oncology, I actually came at it a different path. I did science law first, dropped the law, pursued science, did a PhD in chemistry, postdoc in chemistry, and then really felt a need that if I wanted to make a difference, my skills could be tweaked and better used in another way, and then came to medicine. And having had 3 children, finished my training, I then went back to incorporating research into my clinical work and saw a huge opportunity in melanoma. When I started in melanoma, the survival for advanced melanoma was 6 to 9 months. 75% of people were dead at 1 year, and it was dismal. And so there was the question, this is Australia's cancer, what are we doing? It's the orphan cancer. And from there, just following passion and the questions and working in this team environment, trying to make a difference. And just to echo another point that I think Parvathi brought up, and that was hanging in there. It takes a lot of resilience because there's a lot of up and downs, but geez, it's fulfilling. So that would be my reflection.
Thanks so much, Georgina. Can I actually come and ask you a question that was asked in the very first section, because this is your life. This is your experience. We had a question that a few people have asked about what happens if you do a PhD first, then do medicine? How do you hang in to the research career? And of course, you went and added children in the mix in the middle. Could you just say, are there any advice that you could give people who've done that route where they've done a PhD first, then did medicine and clinical training?
To be honest, I thought it was a great way to do it personally. I can only comment on my journey, but the skills that underlie research are like riding a bike, or in fact, even more inherent than that. So there was no hanging in there for me during the medical training part, because I was incredibly curious. I had not done anything biological. I was physics, maths, pure maths, chemistry. And for me, the hanging in there was just the drive to understand medicine and the biological sciences. And that was incredibly fulfilling for me. I remember I was in that first intake of postgraduate. In fact, when I went and did my postdoc in the US, I knew that was coming. And I remember spending the whole summer learning about infectious diseases, parasites, bacteria, how they work, and it was just curiosity. And so yes, the research was parked in terms of pure research, but that really doesn't matter, because it's about asking the right questions, and that never goes away. And then opportunities open up and you just take them. The other thing I think that was a basic thing I think I've shared with others, and a mentor mentioned to me, was say yes. If something sounds interesting and you're curious, in fact, just say yes. Often, particularly people when they're in their child rearing years, for both men and women now, more so women, you say no because, oh, I'm not going to fit it in. How can I possibly fit this in? I've got this and I've got that and I've still got this and that. But if you just say yes, the priorities seem to manage themselves, and that's how doors and opportunities open, by saying yes if you are curious. So often the first thing people, where our DNA is always about fear, it's, you know, the big tiger there rather than the sunset or the rainbow. So it's in our DNA to think of the worst case scenario often. So presented with an opportunity, we often say, oh, how am I going to fit that in? I'm going to fail. But I just took the opportunities as they came and said yes, and tried to fit it in as best I could.
Thank you, Georgina. That's actually a really lovely response to that question. I think that adds on to what we were listening to before. And the idea about saying yes is really important. But it is great if you've got people around who are supportive of you, which is really good. Henry, I've heard some people who are really interested in surgical or other procedural skills training say, I can't take that much time away from my clinical training and work. Oh, it's okay if I was a physician, but actually I'm a real doctor doing procedural skills. How can I do research and MD, PhD, MD research, PhD at the same time? How do I do that without becoming a dud surgeon? Could you comment on that?
I think it's a very good question, Louise. I think there isn't an answer, but we've actually recently held a little symposium to discuss just that issue out at the Westmead Clinical School, and we had 4 different life experiences. We had one surgeon who did a PhD at the very beginning of his surgical training, and then we had a woman who done it during her surgical training, and then someone who done it right at the end, actually 2 people who done it at the end, and then one as a consultant. So there was a whole buffet of experiences, and there's both pros and cons, but I think you can do it, right at the end, as long as you maintain some, rather like, Prof. Kiernan's comment about maintaining, half a day or some sort of activity that's clinically related. But I think, I'm trying to instill into surgeons that it's the one thing that will give them a job opportunity, because I think now, we're flooding the market with people with a medical degree. We're potentially flooding the market with surgeons, and the one thing that makes you stand out is a higher degree, but also that sort of depth of knowledge that you learn spending 3+ years doing research really is makes you a leader in your field. And I think the penny is slowly dropping in surgery, but it's frustratingly lagging way behind our physician colleagues. But I think you're right, there is a perception, but also I think it's really hard, particularly for women. They feel like it's an added 3 years onto what is already, an initial degree in often science, then an MD, then to do 3.5 years as a PhD along with your surgical training. It's frustrating at the moment, and I'm hoping that the College of Surgeons will actually develop an academic stream. And so I'm really hoping, if they have the forethought to recognize the value of research in surgery, and probably if they could allocate some of that time that's spent on a PhD as part of recognized surgical training, that'll really drag people in. But that's not happened yet, but it's sort of being discussed, and at least that's a start, particularly for women, because my prediction is that women will actually predominate in surgical training and in surgery, but it may, my prediction is it's about 20 years in the future, frustratingly, but my guess is we'll all hopefully live to see that happen. And I think there's some specific skill sets that perhaps women have, particularly resilience and coping with exhaustion, that are innately better than the male, if I can be really sexist. So I would see that as a change, because there's been this historical sort of gender bias, and there still is a big gender bias in surgery. So I hope that tries to sort of answer that question. I think it's really difficult, but you can do it at the beginning or at the middle or the end. I don't think it really matters. You can still become a very competent surgeon, but I think what you gain from that higher degree really sets you apart from everyone else.
Thank you so much, Henry. It's such a lovely, thoughtful response to that. I might also comment that I encourage people who are interested in that to actually look for services, units, groups, group leaders like Henry, who are really supportive of that research embedded training, or at pathways that enable research and that clinical experience to be supported. Whether you're doing surgical training or whether you're doing any others, you want to work in environments that really love it. We can see around lots of places that really love and encourage and support research, and other places that sort of tolerate it. You don't want to be in the places that tolerate it, you want to be in the places that actually love and support and encourage it. So look around for that. I want to ask one of the questions, Nick, this is for you. One of the questions that came is around, because I know about you have worked with MSF and you've had an interesting background, and I think you continue to do some work with MSF. Could you comment about the research opportunities there might be in working overseas, whether it's with MSF or WHO or other global organisations?
Yeah, so my main experience with them has been in the clinical space, but having said that, as I sort of mentioned, you have to find the right NGO that's, is interested in that forward thinking, involving research projects, because a lot of them, it's about service delivery, I suppose you could say, and it's actually delivering care or medicines or surgery to the field. But MSF and others are interested in forward-looking projects that might answer some of those policy gaps or clinical gaps. So I think it's a little bit about searching around for the WHO research centres. In the Asia Pacific region, there's lots of opportunities. I think University of Sydney and other universities also have global health units where you can link into academics, say here in Australia, that have projects underway already. And I think if you're starting out, like you mentioned before, finding that key academic who is engaged in that and saying, look, can I come to your group to assist in a way? Are there opportunities? And then that might open some doors for you in the international space. It's probably harder than national, because and probably harder now because of the travel restrictions, but it will open up again, I'm sure. So I think finding a key sort of person who's in the area that you're interested in the academic, and either in many of the universities, and just asking them what have they got going, and linking in with them is probably helpful. They may already be attached to different NGOs or groups like WHO, etc.
Thanks, Nick. And I'll come back and ask the others more broadly later on about some of these international links. I'll go to Hasantha now, because I know that Has is doing, has worked for many years and with Aboriginal communities on work that's been co-produced with Aboriginal people. And I was wondering, many people are just innately interested in this important area. And I was wondering if you could talk briefly about, if people are interested in this, what might be appropriate approaches.
Yeah, look, that's my main area of research, I guess. So I think the thing to say is engage. I think what a lot of Aboriginal people tell me is that in the past, there are lots of people who came in, took data, took it away, got their PhDs, and you sort of never saw them again. And the community never really knew what the impact was. So I think early engagement, community priorities for research rather than investigator priorities, which is kind of difficult sometimes, because if you have a passion in a particular area and you say, right, I want to work in this area in Aboriginal health, you go to the local community, the community might have 20 other areas that they're really, focused on and the biggest priorities for them. So as I said, the description of how I got into this was a project that was engaging with local Aboriginal communities. They were asked, what are their priorities? Otitis media happened to be the thing that, ear health, hearing, development That was the thing the Aboriginal community said they wanted to look at. And so then they went and looked for someone to engage in that gap. That was the sequence. It wasn't me saying, I want to do a PhD in Aboriginal ear disease. I'll go to the community and force them to do it, sort of thing. So I think that I mean, this is happening all through research, you know, the community engagement. You have to demonstrate community leadership in your grant applications and your ethics applications. So it's not just Aboriginal health, but it's critically important in Aboriginal health, because I think Aboriginal people have been used and abused, if I can put it that way, in the past in this space, and that is certainly not going to be allowed anymore. So I think if you can find the sweet spot where your passions and expertise match community research priorities, which is where I've fallen into, as you know, the way it happened with me, then you'll succeed. And as I said, that project that was discussed with me in 2005, I am still working on now. And so we've had, you know, nearly 20 years of engagement with those exact same communities, all of whom are still with us, for the exact reason that we are doing useful things that they want done, and achieving outcomes. So I would say it is hard, though. It's not an easy thing to do. You have to be patient, and it does take time. It doesn't always fit with those 3-year cycles with PhDs, unless you have done the groundwork or you find the right supervisor who has done that groundwork in advance. It's not a quick fix area of research, I would say.
Thank you so much, Has. So very relevant reflections that you've just commented upon, and I might add to people, Has has been teaching me heaps over the years too about this really important area.
Can I also say, Louise,
well,
just to finish off, I was listening to Georgina, and you said you've got to say yes to everything. I was thinking, I'm trying to say no. The problem I've had is I did exactly what you said. I said yes to everything. Anything sounded interesting to me, and I just said yes. So I think that's right. That's probably how I've ended up where I am. But these days I'm trying to say no.
Georgina?
Can I just qualify? It actually depends on your career, where you are in your career. And so I guess that say yes to everything is at the early part of your career. And then certainly once you're more established and you have leadership roles and you have programs you're trying to produce and ensure, you know, you're mentoring all these young researchers, then you can be a bit more selective. So sorry, I wasn't clear. I meant to say yes at that very important point in your career.
No, I think that's absolutely right, and that is exactly what I did. I said yes to everything. I've got the Academy of Child and Adolescent Health logo here as well, because I've got involved in that academy. It's not a competing academy, so I'm not advertising a competing academy. It works in synergy.
And it's not yes just because that's going to get you somewhere. It's yes driven by passion, which is what you've expressed. And it does go on for years. It's saying yes, yes, yes. And it's really not until I think sort of 15 years or 10 to 15 years after saying yes to everything where you can start being selective like you are now. But that's my feeling.
Yeah, I would say, Louise, sorry, I'll stop talking, but the beauty of a clinical academic position is the opportunity to choose the things that you want to do, and you're not sort of being forced to do everything. Like, I think maybe if you're in an LHD, you kind of have to just do things and do this policy document and do this and do that other thing. The beauty of a clinical academic position is that you can actually choose things that really you want to do and just do those.
Thanks. We might come a little bit later. Actually, Parvathi, you're a clinical academic, if I'm correct about that. Could you just briefly explain to the audience what a clinical academic is, because it's quite a beast, and then I'll ask you another question.
Yeah, look, I am a clinical academic, and I'm currently not based at Westmead, but I'm based at Concord, and so we're part of the clinical school there, and we've recently moved. And so it's a dedicated unit set up for motor neuron disease research and possibly nerve research. So I trained as a neurologist, went into neurophysiology as you call the non-core work, and that's where I got hooked. So what we do now is largely use these skills to conduct research into brain and brain function and disease, and our specific interest at present is motor neuron disease. So as a clinician, what I end up doing is my work is separated out into my clinical work, my private clinical work, and my research work. And the research work is clinical because you are dealing with people, and that's patients, and you're studying them, and you're conducting clinical trials, which involve, like a treatment trial, whatever medication, etc. So in that sphere, you are doing just a disease and looking at all aspects of it. And there are various measurement tools which might be quite unique for that particular condition and which you would not use in the rest of neurology. And as a clinician, then there are days, so I spend a certain number of days doing just my research work. And some days when I'm a clinician, I'm sitting in a clinic and talking to normal people about various neurological problems. And I find that mix to be quite interesting. Because you do need to finish one lot of jobs, and then, on your days when you're doing just your research, you can focus on that work alone. And yes, it's important to have the funding, it's important to have the group and that kind of a safe and kind of a supported space where you can do that kind of work. But if you're fortunate enough to, build your environment such that you do get all of these opportunities, then I think it's just, I enjoy it. And so I would say you just do your work, and it's good to get to work every day, and it's fun to get there and do something. So that, I think, is what being a clinician scientist is about. That's if you like that kind of work, you get some time to do just what you love.
Thanks so much, Parvathi. Folk, one of the questions we've had is about broader academic skills. So not just, not that the word is just, but not only research, but about the broader academic skills and how you can get experience in those. So that could be writing, it might be education, it might be various forms of leadership opportunities. I was wondering if some of you could comment about what you, how that has gone for you, or what you would recommend for people who might be, for example, junior medical officers and so on. I might go to Has, because I know he's got a particular role around education, but then I might ask each of you if you've got additional comments.
Yeah, I think that's another advantage of this role, is that I literally do everything in the CARE, logo for our network, the clinical care, advocacy, research and education. And the beauty of that is just the job satisfaction and, the variety of your day. Like, I can be doing completely different things each day of the week. And I guess I can see myself still doing this in 20 years. I'm not sure I could see myself doing the exact same thing, seeing the exact same patients for 30 or 40 years, but I can certainly see myself doing this because of that variety. So I love education. That's, as you know,
So how can people get experience in developing education skills?
The opportunities for education are endless in the clinical space, obviously. So the whole of medicine is built on that premise that you're taught by your mentors, you do that, the see one, do one, teach one adage, and then you give back to the community to teach. So there's lots of opportunities throughout certainly I work in a hospital, but in either the primary care space or hospitals, to teach junior doctors, medical students, allied health, other interdisciplinary teaching as well. Get involved. Get into it. There are specific educational opportunities for teaching. Now, a lot of clinician teachers don't have any actual education background, if you know what I mean. So there are graduate diplomas and masters and, all sorts of opportunities available both through the university, but also through the, clinical spaces, if you want to get into that in more detail. And come and chat to the education folk in the clinical schools if you're attached to one of the hospitals with a clinical.
Because they will nab you and say, don't worry, and they'll never let you go.
There's no end of opportunities.
What about other academic skills? What about research writing? Georgina, would you want to comment on that? And then I'll ask if the others have any specific comments there.
It's one of those critical skills, actually, that all of us in life, if you can write, it puts you in such a better position for any career, I think, whether it be nurse, anything. So I must say, I stress that to my children. You've got to learn to write, do your English, because no matter what you decide, even if you're going to be, you know, a mathematics genius, writing is so critical. So when it comes to research, I see writing as an apprenticeship. It's a skill within itself. And the best advice I've received and have handed on is just get in and do it. And so opportunities to write up small cases, to then start small research projects and writing them up, writing grants. It's an apprenticeship. And it's really interesting because when people miss that apprenticeship and don't get that opportunity, and it's you know, getting that paper back from a mentor with red track changes everywhere, learning all the subtleties and the way to express something very distinctly, and then read it at the end and say, yeah, I get that. Or putting together an abstract where you get that spoon-fed, yep, I know what they've shown. Achieving that is really, really hard, and is a skill, and is it practiced, and it's an apprenticeship. So it's two ways. It's opportunities for junior people, in my view, to write things, and then to have the time as a mentor to correct it. And that's very time consuming for the mentor as well, to teach that apprenticeship. And it's sometimes harder and easier. There are some people who just have the skill, and you develop that as well. If you find someone who can develop it, you know, I'm always one to support. If you've got the talent, just shove everything you can at that talent and let them blossom, and they'll blossom on their own. So yeah, apprenticeship is what I see writing as. Practice.
Thank you. Thanks, Georgina. I think there's some really good lessons there. But Kate, audience, a lot of you will have the opportunities, if you want, to write up, say, an interesting clinical observation case study, or case studies, case series. Your bosses will want someone to do that. That's a great starting point. Henry, I want to ask you about some of the broader issues around leadership and broader roles that can come in linked or parallel to being a clinician researcher. A lot of clinician researchers are also leaders in health system or in broader professional groups and so on. Can you talk about opportunities people might have to develop those leadership skills?
Yeah, I think actually I probably took on Georgina's advice a long time ago, and I didn't learn how to say no. In fact, my wife Karen, she teases me because she says, "Just say no, for goodness sake." But I haven't learned that word, so I tended to just accept opportunities. And of course, it's more work, but someone's got to do the work. I mean, it's a bit like education. If you're interested in teaching, then absolutely we would love to have your help. So we're never going to refuse you. But that would be my experience in terms of leadership roles. And in my sort of particular craft group, you know, there are so many tiers of governance at local level, state level, national level in transplantation and organ retrieval in terms of the ethics of retrieval and so forth. So I've said yes to everything, and therefore I suppose part of the thing is I've surprised myself that I've really enjoyed it, because it gets you to meet and interact with people who are not surgeons. So, but of course they're also very intimately involved in your specialty, but in a different way, you know. But we're all part of the same team, and I think that would be probably my also take-home message about getting involved in teaching and education, is that it actually means you interact with, you know, an educational designer. You know, it's lots of different skills that I don't have that they have, and I'm sort of in awe of their IT skills in creating, you know, say a unit of study that would have taken me the rest of my life to do. You know, I mean, so I suppose it's that opportunity. You just seize it, and I think it's not a planned thing. You don't say plan to be, you know, the chair of such and such or the chair of that. But it's interesting how things just move from one to another. And I think if you're willing to say yes, but also you actually do the work, there's no point having people who put their hand up and then actually don't do anything. And I suppose you rapidly recognize those, and then they don't get asked again. So yeah, I think Georgina's right, but she's probably so successful she can now say no. I don't see myself as ever being that successful. So I think leadership's a strange thing, because I've never seen myself as a surgical leader. And yet I suppose I am, but I would never see myself as that. I just see myself as a plumber, you know, in many ways. And you probably don't realize I've spent my whole working life either on call every day or at the most 1 in 3. So most of my life I've been on call every other day for some form of transplant surgery. So since 1999. So I'm after this, I'm going to do an operation that'll take about 6 hours. So, you know, I have a very different existence. And that's why I often feel like I fail in many aspects, because you can get quite tired. But all you can do is your best. And I've reached that sort of phase where I just accept all I can do is my best. And that will have to do. But I do love the different facets, a bit like Has. I love the different areas of your life. And you cannot get bored. You just, even in a pandemic, you cannot get bored. So I think that's a bit of a blessing for those that are interested in other things rather than just pure looking after patients, because that's part of it, but it's not the whole package. And I think, you know, a lot of clinicians can get very I suppose dissatisfied with their careers in the longer term if that's all they have. Whereas I think everyone who's panel this morning, you can see just how varied and talented and diverse their interests and skill sets are, which I think is that's the way to have a career. It's not to be so sort of focused on one tiny area.
Thank you, Henry. You are a Renaissance man, and it's wonderful to have Renaissance men and women here on the panel. But we've had a question, which I actually think is it better? Is there? It's more a reflection on it. Just how does research get funded? Is it better? Is there a better way to streamline research based on need? Is it based mainly on funding for a particular area? You know, because at the moment we could think of COVID, but if you could just reflect on some of the, if someone wants to comment just around how you get funding for the areas that you're interested in, or the areas that we think are high need. If anybody wants to raise their hand or just unmute and comment. Nick, is that you unmuting?
Yeah, yes, it's a tricky one, funding, because in my space, what we've sort of been able to do in some sense is you have to, if you can, over time, build a bit of a team. And building a team, I think, is hard to do without money. Unless you're lucky to get given, here's $10 million, go build a team. And so how do you build a team? Because as you go further up, you sort of have to show that you have a team, you have another group of people that you're responsible for, etc. And so what we've been able to sort of try and do is use pharmaceutical funded trials to use some of that money to then employ research assistants that we can employ to work on investigator-led sort of trials, if that makes sense. So it's a hard way to do it. I think funding in Australia is particularly difficult. I sort of feel it's very competitive across the country, and the problem there is that doesn't really encourage collaboration, to my view, as much as we probably would like. So I think funding is tricky. We've been able to do it by sort of leveraging the pharmaceutical money a little bit to, you know, employ research staff that can work on more of the academic side of things, and then you can build a team that way. Once you dip your toes into the academic space, get some outputs there, then hopefully you can get the philanthropic or the competitive grants, and then you start to build a bit of a way forward. So the starting's the hard part, I think, Louise, and so either thinking of a clever way to get funds in that are non-grant or non-competitive money, or working with an institute where you've already got a bit of a team that you can join and then work your way up through that team would be my comment.
I think that idea about being able to work collaboratively with other people, and I know that Nick works with, for example, the National Centre for Immunization Research and Surveillance. So that's a really lovely group of people who have some specific funding, and I know several of you work in that environment. Did you want to talk about research priorities, research funding, and all those challenges?
I was just going to say, funding is a red rag to a bull to a panel of researchers, that topic. And I think you've got all clinician researchers, which is a different, world entirely to the lab researchers, who I just don't know how they do it when you're applying for grants for your job. So I've got a clinical academic tenured position, so I'm okay, and then I apply for these grants that have 5 or 10% success rates and hope for the best, which I don't know whether the others do as well. It's a very difficult area. But I've been quite lucky with grants, but I'm just saying it's very, very hard, because you have to have that sweet spot of being in an area that is community-driven research priority and an NHMRC. I only work in NHMRC grant space. I don't have drug company opportunities, so it's extremely hard. And that's a whole different topic, I think, is redesigning the NHMRC process so that it works, for research priority areas. And people think Aboriginal research is awash with money because it's a research priority area. But if you actually look at the NHMRC grant outcomes, you don't see like 40% of the money going to Aboriginal projects by any stretch of the imagination. It's about where, the proportional population is. So I don't think there's anywhere near enough done personally. But anyway, don't get me on my soapbox.
I suspect we all agree that there's inadequate funding, that you've got to be creative around this. And one of the issues here is about working with teams who have experiences in this area. Georgina, you'd like to?
May I make a comment just to stress what both Nick and Hus have said, picking up on 2 points. Number one, the team part is so important. And that beginning part, trying to get the team together, you actually give up a lot. Personally, as a clinician, I gave up probably 5 years of high income. I was self-funded on little bits of grants, not high income, I just say income equivalent to my colleagues, I would say, just because of the passion. But what resulted was this slow building of a team that was very effective. But that took years of sweat, and also the focus on the team, getting the right people in part of the team. And then once we built the team, then funding started to come, and it was in a similar way to Nick said, basically starting small. I think we started with a trials group of 3 staff. We've now got 26 full-time staff. We've now got a whole unit that just does investigator-led studies, so we can put through protocols. We see, in excess of about 150 patients a week. And then that has enabled us to fund a lab, which we have at Sydney Uni, which has 25 people in it. So the basic science part, which I agree with Hus, I cannot imagine how hard it is, because it's hard even when you have these extra opportunities within clinical work. But we've been able to support basic scientists so that we can get that translational laboratory and the clinical trials. And it's just, it's hard work. It's hours and hours. So Henry, agree with you. It's a lot of time, constant time and passion. And so, by the way, we say no to things that aren't our field anymore. So if someone gives me something on infectious diseases, I'll say, no, that's not my area. But it's that team, big picture. It's not just about what I am doing, it's about what we're trying to achieve as a group and how we need that basic science, and using the clinical to leverage that funding to support basic science. I just wanted to, it's tough. It's a tough area, and it's hard, but it's worth it.
One of the things I've been struck by, that all of you have talked about how important it is to collaborate and to connect with other people, and the previous speakers talked about networks and so on. I actually think that's part of the thing that works. None of you is a lone range researcher, just sort of in your silo. You're working with groups of other people. Parvathi, can I ask you about what you think supports growing collaborations in those networks? What do you have to do? Maybe what did you have to do as a younger researcher, because that's our audience, to actually enable collaborative work or to build those networks? What were some of the things you found helpful? Apart from yes, I'll do it, but maybe yes, I'll do it is part of it.
Yeah, it's about if it's an area that you are interested in, you follow people. And I think, we haven't done a lot of it in the last 24 or 12 months at least. Meetings, where you have these people presenting is a great opportunity. Go and meet somebody. Oh, I really like this area of work, and can I come and work with you? And how does this fit in? And do you think it can, have some translation into my field of work? So one is you keep your eye out for things or questions which bother you or you need answers for, and you see who's doing the work in that field, and then you maybe make contact with them. And if you could do that in person, which we were doing earlier at our big international national meetings, that's a great opportunity. So you find the people who are willing to work with you, and then you see if you can set up a collaboration, or you put your hand up and say, look, this is something we could do, and could we have a collaboration? So I think it's identifying the people. The question usually comes from the work you do and the literature that you're reviewing for your own work. And you realize that these are the people who are doing more works in these specialized fields, and they're the ones you should go and ask for help or for collaboration. And that's the way I think you build your network. So, like I have my area of expertise, which will be neurology, neurophysiology, and I'm doing ALS research, but the whole brain interests me. And I know that there are some people with special skills in radiology and genetics, in proteomics or immunology, and I really don't have that much of a skill set. But if I was interested in a specific aspect of their work which involved mine, then I'd be going and asking that person, you've done this in your area, do you think you can help me translate into what I do? And how could we set up a collaborative project? That's how these projects start out. So when a person is starting, like for the young researchers or the young students who are currently watching, I guess the idea is what's interesting you, and who are the people doing the work in your field? Can you go and ask them and find out, like how could you fit into their work, and could you gain something from their knowledge and bring it back to what you're doing? That's how the translation happens. And having these institutes, like so at Concord, we had some students presenting from the ANZAC Institute. And I was fascinated to hear about how they were using botulinum toxin for burns work. And that we use botulinum toxin all the time as neurologists for various neurological disorders. But this was a totally interesting area. And then I thought, wow, this is something maybe we could think about, how either we can contribute our knowledge about the product and how we use it clinically and see how that helps in burns work. But that's what I mean. So listening, or, your university helps you find groups doing special interest work, and you plug into those and find out who are the people who I can work with, who are the people who have ideas which I can, kind of borrow from or learn from. And I think that's the way you build your networks. And when you grow in that process, then you're basically looking at people who can help you with your projects by bringing in special information or skills, which is really valuable.
Thank you so much, Parvathi. Folk, we're right near the end of our session. And what I'm going to do is ask each of the speakers to come up with 2 or 3 phrases that they'd like to suggest to the medical students or junior doctors listening that might encourage them to think about what skills or things that they could do, the advice they'd give. So just 2 or 3 short phrases, and I'll go through in the order that I first introduced people, and then I'll, in the process of wrapping up. Can I just say what an amazing group of people, and I could talk with you for much, much longer, but we do need to move on to other things. So 2 or 3 phrases to capture some of the advice you'd give. So Henry, to you first.
Actually, first of all, I wanted to just end by saying, thank you so much for chairing this session so well, because that's a skill in itself, which is fantastic. So well done to you. But I was going to say, be the very best you can be, and don't focus on everyone else around you, because there's going to be people better than you, but they're not you. So if you can be the best for you, then you're a winner. Do you know what I mean? And I think that's helped me. It took me decades to come to that conclusion. Just be the best version that you can be, and don't see it as a competition, because there will be cleverer people, more talented people. That's not important, because they're not you. That will be my take-home message.
Thank you, Henry. I'll go to Has now.
Yeah, so I just want to add one thing about the research scholarships as well, because money is a big issue. Obviously, we have to be blunt about it. And the research stipend's only 30 grand tax-free. But just remind young clinicians, you can do what I did, which is do locum work as a clinician to augment that salary. And, you know, you can do 20 hours a week. So don't be put off by financial considerations, because in the long term, it'll be much better for your career to have a higher degree, whether it's a PhD or, you know, master's or anything. And the other thing I would say is think about whether you could keep doing what you're doing right now for 30 or 40 years. And when you're a junior doctor, what happens is you change every 10 weeks. So you do something for 10 weeks, you do something for 3 months or something, and then you move on. So just imagine that 3-month term for 30 years. And if you can do that and you're happy, then you might just want to be a clinician. But if you think, I'm not sure I could do nothing but that for 30 years, then, you know, clinical academic might be the thing for you, because you can do a bit of that and you can do a bit of this and a bit of something else. So, you know, I feel like it's almost like you're paid to think to be an academic. Like, how do I get away with this? Someone's paying me to think. So,
okay. Thanks, Has. On to Nick.
Just to really echo what the others have all said, two things for me would be that the clinician science life is variety. Like Has said, it's different pieces of the puzzle of life, which I think is exciting and interesting. And the other thing is the satisfaction of the unanswered question, trying to chase that down. Can you, and particularly in my space, it's the policy relevant sort of gaps that you may well be able to fill that sort of gap. And that's exciting. So there's that sense of satisfaction. So they're the two things, variety and satisfaction.
Thank you, Nick. I'll go to Georgina.
Make a difference to many, say yes, and learn to make a decision. Run with it, no regrets. Decision making can be tough, but you've got to practice it. So make a decision and learn from making decisions, good ones or bad ones. To be a good decision maker, you've got to practice decision making. They're my 3 take homes.
Thank you so much, Georgina. And Parvathi.
Yeah, thanks, Louise. I would say one of the things is find a good mentor and a good group, because that is sometimes what survival is all about, because they keep you going. And the second thing, which is really important, is pick a field which you're passionate about, which you love, because there will be times when work is difficult, answers are not there. But if you still love what you do, you still find that energy to get up every morning and go back there and do it.
Thank you so much, Parvathi. Look, I've just so enjoyed this last hour listening to you and speaking with you. And I know that we've only answered some of the questions that the audience has asked. Audience, I'm sorry that we couldn't get to all of those questions, but we are time limited. I do encourage you locally to follow up. So wherever you're working, whether you're rural or in metro settings internationally, I do encourage you to seek out the clinical leaders where you are, those who have a passion about research, and start to talk with them and find opportunities. Keep an eye out, look out for those case studies. As students, there are a lot of people, because as students, you'll be interacting with academics a lot of the time, lots of opportunities to go and have conversations and to find out opportunities there. And we love talking, as you can tell. The Australian Academy of Health and Medical Sciences is very thankful for the sponsorship that we've had for this. So that's from the University of Sydney and the University of New South Wales. And we really thank those 2 universities for the support that they've given to the Academy for us to run this webinar. We were originally planning to do it in person, but of course, COVID restrictions meant that we couldn't. And we hope that in the future, we might have a mix of hybrid events, both in person and at a distance, to allow that to happen. So please stay tuned, and we hope that this can be an annual event supporting all of, so that we can bring together medical students, junior medical officers, and other allied health and nursing equivalents, so that we can encourage people to think about research as an embedded career in their clinical work. I think you've learned heaps from this audience, these speakers, and I want to thank Henry, Has, Georgina, Parvathi, and Nick for the amazing conversations that we've just had. That's been incredible.